Got 15 minutes before morning is over, but great session so far. Um, I'm Lamont. I'm a facial plastic surgeon and a translational research from Henry Ford Health in Detroit. It's an honor and a pleasure to be here. I look forward to this meeting every year. It's a great way to engage with like-minded individuals from the whole spectrum, from patients to people that are doing translational research. So today I'm going to talk about transcriptomics of keloids, fibroblasts, and immune cells. So I'm going to give a little bit of basic science to support that. We know keloid is an immune-driven condition. So when we look at disease in general, cellular heterogeneity is important. Especially for keloids, we used to just describe that there's fibroblasts there. We know the fibroblasts make the collagen, but we also know that there are other cells that are involved. Keloids, like other tumors, like for cancer, we know that the most prominent cell isn't the cancer cells, actually the other cells in the tissue microenvironment. And I think, that's the case with keloids. The difference is because it's a benign condition, sometimes they don't look that interesting. And that's the reason why we need to get more understanding of what's going on in the cellular level. And I think once we understand this, we will be able to, one, know more about the disease. Two, we'll be able to decide on which treatments. We talk a lot about treatments. One of the talks that I gave last year is that the thing that's common between all treatments, surgery, cryotherapy, radiation, is that we all have recurrences. And if we didn't, then this meeting wouldn't exist, and one of the things that allow us to understand what's going on with disease is understanding the cellular heterogeneity. And we know that you can have a patient that has multiple, let's say, ear piercings, and they'll develop just one. They could have 6 on one ear and just develop one. Or you can have a patient that has multiple keloids, and you can treat them all the same, and some will recur and some won't recur. You can treat them differently, and some won't recur. And so understanding the cellular heterogeneity, I believe, will allow us to understand what treatments to use for patients. And I think it's important for this novel drug development. So again, cellular heterogeneity, we know fibroblasts are the workhorse for keloids. If we look at single cell studies, there's only about 3 or 4 that have been published. These are published in Asia Pacific. But when we look at the skin and fibroblasts, there's the study that most people use. There's 5 types of fibroblasts that are sort of recognized: pro-inflammatory A, B, mesenchymal, secretory, papillary, and reticular. So when we look at the single cell studies that have been done, they show that there's a specific increased abundance or number of mesenchymal fibroblasts. And this increased abundance separates keloid tissue from normal tissue. And this is matched normal and unmatched normal. So, most of the matched normal is adjacent to the keloid, and there's question whether or not it's normal or not. And also it distinguishes, the abundance distinguishes keloids from other non-keloid scars. And so, like I said, most of them are from Asia Pacific. In the United States and in Africa, I mean, I'm unaware of any single cell studies in Africa, but I can say for sure in the US, there's no single cell studies in African American patients who have the highest incidence and the most aggressive disease. So one of the things that we've done, I actually have done single cell. I'm not going to talk about it today because that's going to come out with a paper. Maybe next year I'll be able to present it. But what we did was, there's a way that you can take bulk RNA sequencing data and infer the cell types that are there and get an idea of what these cells are doing. And so what we did was we took 14 patients, 10 were of African descent in the US, and 4 were of European descent. All of the samples were from the head and neck area. I think that, when we look at studying keloids, there's no question that there's a lot of heterogeneity that's going on, but location is one of them. So we focused on head and neck keloids. We then did RNA sequencing. We looked at those 5 fibroblast cell types that I talked about, and then there's a way to bioinformatically look at 22 immune cell types. And this is it's called CyberSort X. It's above my intelligence, but I work with a really good bioinformatics person, and you can infer these cell types, and then you can look at what types of genes and pathways are associated. So we used a statistical method to look at differential tissue expression between the keloid and the matched adjacent normal. And again, we looked at those 5 fibroblast cell types, the 22 immune cell types, and then we use something called ingenuity pathway analysis, where it can infer what pathways may be activated and what genes are involved. So this is the patient group. So the average age was 38.4, which fits in that third 1 to 3rd decade of life. Like I said, there was 10 of African descent, 4 of European descent, and this is the sex makeup and the location. So most of them were ear keloids. So when we looked at the subtypes, 3 of the subtypes of the fibroblasts were distinguished between a keloid and the matched normal. So if you look here, oops, didn't mean to do that. Test the time. Okay, there we go. Thank you. So if you look here, the pro-inflammatory B and mesenchymal and the secretory reticular were increased in keloid tissue compared to the matched normal tissue. And when you look at the immune cells, so out of the 22 immune cells for keloids, B cells, mast cells, activated mast cells, M1 and M2 macrophages, CD4 memory cells, and natural killer activated cells were increased. And this is data that's consistent with in the literature. We know that M2 macrophages is the most common immune cell in keloids, and it's higher in keloid tissue compared to normal tissue. There was previously a lot of information about mast cells and keloids, and so this again helps to sort of support the whole idea that the immune system is involved. When we look at what was increased in the matched normal tissue compared to the keloid tissue, these cell types were the most common. So eosinophils, dendritic cells, monocytes, neutrophils, T cells, resting mast cells, as opposed to the activated, and then Treg cells and T gamma delta cells. So the other thing we did was we wanted to see what the association with these immune cells were with fibroblasts. So what are the pairs, the interactions? And when we looked at the cell types that were increased in keloids compared to normal, the adjacent normal, there's 3 categories. So you could either have increased in keloid tissue and down in normal tissue. You could have down in keloid tissue, increased in the adjacent normal, and that accounted for the majority of the pairs. And then you could have increased in both. And so when we look at what was most common in the first pair, it was the natural killer T cells that are activated in T cells, and the second was for the third pairing was follicular and pro-inflammatory, and then for the first pairing, it was circulatory, reticular, and eosinophils. Then we looked at the gene expression. So the other bulk RNA sequencing papers didn't account for the cell type enrichment. So the problem with, if you don't account for that the fibroblasts are the most common cells there, you can get data that can be biased because you didn't account for the cell type. So what we did was we looked at, we controlled for the cell types. After doing quality control, there were 15,753 genes. And then after looking at, after controlling for the cell types, there ended up being 1,145 cells that were statistically significant at a adjusted p-value of less than 0.05. And these are the top 15 genes that were present after controlling. An interesting thing, the most overexpressed gene was a long coding a long non-coding RNA called MIR31 host gene. And the interesting thing about this gene is we published 2 papers before looking at microRNA biomarkers. And MIR31-5P was a biomarker that distinguished keloid from normal tissue. And we also showed in a subsequent paper that its increased expression was associated with a decrease in recurrence after surgery with or without a steroid injection. So this is using IPA or ingenuity pathway analysis. So again, you take those genes, you put them in the pathway analysis, and it gives you an idea of what pathways are activated. And a z-score of a positive z-score is associated with activation, and negative z-score is associated with decreased activity. And when we look at the pathways for these genes, the same canonical pathways come up. So pulmonary fibrosis, hepatic fibrosis, collagen biosynthesis. So these are all pathways that we know are activated in keloids, which just gives more credibility to the results that we were able to show. So in conclusion, the studies revealed that fibroblast subtype enrichment, heterogeneity, and keloid tissue is related to different immune response. So certain fibroblasts are related to immune cells, and that further studies are needed in order to better understand cellular heterogeneity in keloid tissue. And just like in other diseases, so asthma is probably the poster child, where they've looked at the immune response and the failure of steroids to help patients. And they've been able to endotype patients and direct treatment based off of the type of immune response that's occurring. And just like all the talks before, whether or not the stimulus is the microbiome or whatever it may be, we know that the immune system has a important role. And in the past, we've basically focused mainly either on fibroblasts, or keratinocytes, and understanding how the cells interact with each other. We believe, at least in my lab, that this is how we're going to be able to segment patients between responders of certain treatments and non-responders. Thank you. So I think we're a little bit out of order. I'll let Frank.